Hi everyone, good afternoon. It's so great that so many have joined us. I feel really privileged to chair this webinar today. At the last minute, we've managed to pull together some fantastic speakers, some who've absolutely stepped in at the last minute. I'm forever indebted to you. And in saying that, I also need to give a really big shout out to Darby from Public Health Scotland, who's helped me with this. Before we move on to the webinar today, it doesn't feel right not to acknowledge the 1,330 people who've died as a result of drug use this year. And our thoughts truly go out to the people affected by the loss of their friends, their families and carers. So this year, our theme of our webinar is Scotland Can't Wait. The World Hepatitis Organisation campaign this year is themed I Can't Wait. And their message is, with a person dying every 30 seconds from a hepatitis-related illness, we can't wait to act on viral hepatitis. People living with viral hepatitis and are aware can't wait for testing. People living with hepatitis can't wait for life-saving treatments. Expectant mothers can't wait for hepatitis screening and treatment. Newborn babies can't wait for birth dose vaccinations. People affected by hepatitis can't wait to end stigma and discrimination. Community organisations can't wait for greater investment. Decision makers can't wait and must act now to make hepatitis elimination a reality through political will and funding. It's such a powerful message, and it's one that Scotland's been working hard to implement with their ambitious target of 2024 hepatitis C elimination. We're all eagerly awaiting the latest sexual health and BBV framework and funding to allow us to continue this amazing work towards hepatitis C elimination in Scotland. We've got a really inspiring programme for you all today, and I'll just quickly run through it. So starting us off, we've got Professor Sharon Hutchinson from Public Health Scotland, who is an epidemiologist. And she's going to tell us a little bit about monitoring progress and challenges in reaching hepatitis C elimination. Sharon's going to be followed by Pauline Dundas, who's the lead hepatology nurse specialist in Aberdeen, and she's going to share a presentation on postal dry blood spot testing for bloodborne viruses. We will then be joined by Professor Dillon, who's going to give us a presentation on developing the foundations for elimination of hepatitis C and evaluation of pathways to reach whole populations. And finally, our last presentation of the day is a video with Billy from Hepatitis Scotland interviewing Scott, who was one of Billy's volunteers, who's been through both the old and the new treatments, and he gives us some real insight into the difference between both. Lastly, we're going to have a Q&A session where the speakers will be joined by Alastair Hudson, who's the CEO of HIV Scotland, and he's got a wealth of experience around postal testing as well. So with all that being said, if you've got any questions, please pop them in the chat. We will try to answer as many as possible. Get comfortable, relax and enjoy the webinar, and I'm now going to hand you over to Sharon.
I'd just like to say thanks to Norma and the team at Hepatitis Scotland and Scottish Drugs Forum for setting up the webinar today on a really important day for us. I'm going to present on our efforts to monitor progress on hepatitis C elimination and the challenges we face, particularly from a Scottish perspective. And this is just an outline of my talk. I'm going to do a quick recap on the targets on hep C elimination, both from a global and a Scottish perspective. I'm then going to touch on the progress we've made in Scotland in terms of hepatitis C elimination and talk you through some particular aspects where we have data on. And then look at what impact the pandemic has had on Hep C services and elimination efforts and key challenges going forward. So this is, these are the global targets set by WHO on hepatitis C elimination. And in June 2021, WHO published some interim guidance for countries in terms of validating progress on elimination. I just kind of would just talk you through this, and you'll probably be most familiar with the high-level impact target set by WHO in terms of reducing the incidence. That's the number of new infections each year by 80%, and reducing mortality, numbers of people dying from hepatitis C related disease by 65%. These are targets set for reductions between 2015 and 2030. Now, WHO recognizing that actually very few countries have good data to understand their status as at 2015, they've actually introduced these population rates as well for 2030. So countries can assess what progress they're making towards these population rates, with mortality here in particular set at 2 deaths, Hep C related deaths per 100,000. We have the other targets on interventions here in terms of reaching a target of 90% of infected people diagnosed by 2030, 80% of people diagnosed need to be treated by 2030, and then other prevention measures as well. And the key one here for us is having very high coverage of needle and syringe provision. Now, these targets are very difficult to measure, and I think recognising the challenges in terms of countries measuring incidence of new infection, there's an additional proxy measure that WHO have introduced in terms of reducing the prevalence of hepatitis C, that's chronic infection, by 80% by 2030 in the general population, or also in terms of people who inject drugs. And that's the key population, of course, for us in Scotland in terms of the core group that are at risk of infection. Those were the global targets with a date of 2030. Of course, Scotland has set more ambitious targets with a year here of 2024, of course. So within our strategy that was endorsed by the Scottish Government, not only do we want to achieve the targets set out by WHO, but you will also set a couple of other more ambitious targets in terms of prevalence of infection. We have aimed to reduce the prevalence of infection down below 5,000 by 2024. That translates to a percent reduction of the order of 85 to 90%, so more ambitious than the WHO target. And also reducing the numbers of people developing very serious consequences of hepatitis C, liver failure, liver cancer, or death from hepatitis C, bringing these numbers down to below 10 per year. Now that translates to a threshold around 2 per million population in Scotland. So again, a much more ambitious threshold that's set by WHO. And then let's look at the progress that's been made in terms of scaling up DAs and community drug services in Scotland. These are data that we obtained through a national survey of people who inject drugs, referred to as NESI. On the left-hand side here, we've got the self-report data on the uptake of hepatitis C treatment among those who would have been eligible for therapy. We've split it according to Tayside here and the rest of Scotland. You can see the real major progress that has been made in Tayside in terms of scaling up treatment, up to close to 80% here in late 2019, early 2020. Still also progress being made in the rest of Scotland here, close to 50% reporting that they have been treated for their hepatitis C by late 2019, 2020. And that has been done here on the right-hand side through delivery of testing and treatment, particularly particularly in community settings and other services engaged with individuals affected by hepatitis C. So the minority now, certainly in Tayside, 16%, are being initiated on treatment within hospital settings. The majority is now being, people are initiated on treatment with hospital settings. And I'm sure John will talk much more about the pathways in terms of delivering hepatitis C elimination in Tayside here. There's been a coordinated programme of work across multiple settings within community agencies such as pharmacies, drug treatment settings, prisons, enhanced needle exchange services and other outreach settings. So this is a coordinated programme that has enabled the major and rapid scale up of services in that particular region. So what has been the impact of that scale up of DAs? Has it led to a reduction in prevalence? And here are our data again from our biosurveillance survey. And we can see for Tayside, where we've had the highest level of scale up of treatment in that population who are injecting drugs, what we observe is a 70% reduction in prevalence in that area, reducing from here around 34% back in 2013-14. We're getting down to around 10% prevalence in that population by late 2019, early 2020. So not quite achieving the WHO target of 80% reduction, but very close to achieving that WHO target. Also, you can see here, I've pulled off separately Greater Glasgow and Clyde, where we also see quite considerable scale up in treatment in that population. As you can see, at much higher prevalence we had at baseline for individuals who had injected in the GGC area, close to 50% here. That is now coming down below 20%, 60% reduction. And indeed, we've seen progress in the rest of Scotland in terms of a 30% decrease. So across Scotland as a whole, we've seen around a 50%, a halving in the prevalence of Hep C in the population injecting drugs by 2019-2020. These data are pre-pandemic, and we're making strides and progressing with plans to do another national survey commencing later this year. And that's going to be critical for us to understand where we are with prevalence of hepatitis C and what's happened over the course of the pandemic. In terms of undiagnosed hepatitis C infection, here again, progress being made in terms of reducing the percent of people that are unaware of their infection. If you focus here on the red line, here I've done it in terms of amongst the total population who are injecting, not just those who are chronically infected. Here, back in 2010, this was close to 20% of that entire population who were unaware that they're infected with hepatitis C. And so we're getting that down to close to 10% now by late 2019, early 2020. Now, the impact of the pandemic, this has been summarised in other papers, notably this one by Kirsten Trainer, and in terms of the impact on hepatitis C prevention services, both the impact and also the measures that were introduced and services that were adapted to address the impact of the pandemic. And so what we had faced is that there was a reduction in face-to-face service provision. There was a reduced capacity in terms of staffing to deliver these prevention services. We also had reduced capacity in terms of testing for bloodborne viruses as well. But services have adapted and delivered these initiatives in different ways, and I'm sure we'll come on and hear a little bit more about that in terms of needle syringe provision. This was delivered in different ways. It was the numbers of needle syringes that individuals could receive at each transaction were increased. Other things were encouraged in terms of secondary distribution. Also in terms of OST, there was a shift from supervised supervision and a shift away from daily dosing, daily dispensing. And also we had the introduction of long-acting injectable OST. And outreach has played a key part in how we can continue to engage with this key population. So let's look at where we stand in terms of harm reduction service provision. These are data we have in the numbers of needle and syringes that are distributed across Scotland in terms of key health boards. According to different years, the blue bars show the 4 weekly totals in 2019. You can see around 200,000 needles were distributed in each of those 4-week period, typically in 2019. We can see the hit of the pandemic in terms of reducing that needle syringe provision. Initially here in weeks 13 to 16, there has been a little bit of recovery in that, but we remain 25% lower in terms of needle syringe provision compared to what we were pre-pandemic. Now, we don't know whether injecting practices have changed, and so we might still see high levels of adequate needle and syringe coverage. We'll get into that a little bit more once we have the survey of people who inject drugs later this year to know to what extent the pandemic has really had in terms of coverage of needle syringe provision. Then in terms of looking at the impact of the pandemic on hepatitis C test uptake in key population here, in terms of people that are prescribed opioid agonist therapy, you can see the orange line here. This is the proportion that had ever been tested in that population group. That's gone up year on year. We're getting up to 90% of that population had ever been tested pre-pandemic. But if you look at the blue line here, whilst we're getting up to around 50% that are being tested each year within that population, you can see the impact of the pandemic that's reduced that proportion down to around 1/3 that are being tested each year. So around 2/3 have not recently had a test in that population group, and that's a key area in order for us to address going forward. And that plays into the numbers of new diagnoses. We have observed here, again, comparing pre-pandemic, the 2019 in green, compared to years relating to the pandemic. And pre-pandemic, we were getting around 100 to 150 new diagnoses each month. You can see the impact of the pandemic. In April 2020, that came down to only less than 20 in a particular month. There has, you can see, in progress there, and increasing numbers of new diagnoses, but we're still 1/3 lower in terms of new diagnoses compared to where we were pre-pandemic. And it also that plays into the numbers of new treatment initiates. Again, the pandemic has played in quite significantly here in terms of reducing the numbers of people that have been able to go on to hepatitis C treatment. And in recent months, we still remain around 50% lower than what we were pre-pandemic in 2019. Now, a key factor that we need to also consider in terms of hepatitis C elimination is the extent of reinfection and our ability to promptly diagnose and treat those who become reinfected. On the left-hand side here, we can see the dramatic rise we've observed in the numbers of people who are injecting drugs that have been initiated onto hepatitis C treatment. And the middle grey bar here reflects the widening of that treatment into community settings. That has grown with the availability of direct-acting antivirals. But as we expand treatment into these communities and to individuals that are higher risk of infection and reinfection, then we also observe higher rates of reinfection in that population who are being treated within community and prison settings. So on the right-hand side here, since 2015, and in the 4 largest health boards, we're getting on close to 2,500 individuals who we have initiated onto treatment by 2018. Something in the region of 300 and 400 we estimate have gone on to be reinfected. But only around half of those we estimate have been diagnosed with their reinfection. And you can imagine as the pandemic has gone on, we've got lower levels of testing, then a reinfection could continue, but we might not be picking them up because we're doing less testing. So if I can just make a few conclusions, then Scotland is one of the few countries that can demonstrate really major progress on the WHO global targets on Hep C elimination. We've demonstrated it's not only feasible to majorly and rapidly scale up treatment among people who inject drugs, the key risk group. And we've also demonstrated it leads to immediate reductions in the prevalence of hepatitis C in this population. And that has been achieved through coordinated strategies where Hep C and hepatitis C testing and treatment is embedded and co-located within community settings alongside drug services and harm reduction services. Hep C reinfection rates have gone up related to the scale up of DAs among people who inject drugs in community settings. And so a key challenge for us is to scale up, I think, testing, particularly in that population as well, who have recently achieved an SVR in order to diagnose and retreat any individuals who have become reinfected. And I think testing is going to be really a key for us in terms of recovery since the pandemic and addressing the shortfall in testing we've seen during that the last few years. From an intelligence side, we're making inroads here to getting back on track to delivering our surveillance, monitoring surveillance data, but we've still got a way to go in terms of addressing some key gaps in terms of prevalence of infection, not just at a national level, but for each health board. Those are going to be key to direct further efforts in terms of elimination. Thank you very much.
Thank you so much for that, Sharon. There's so much information there, and I think it's great to see how much progress we've made, and what I do know about the kind of bloodborne virus workforce is that there's a real will and determination to kind of drive this through. I think, again, so much innovation out there. And next up, we've got Pauline Dundas, who's the lead hepatology nurse specialist from Aberdeen. And she's going to talk to us about one of those innovations, which is postal testing. So I'll hand you over to Pauline.
Hi everyone, this is what I'm going to talk about today. Unfortunately my slides aren't as fancy as Sharon's, but hopefully they get the message across. Next slide please. So why do we need self-tests for bloodborne viruses? Well, as Sharon's already said, the COVID-19 pandemic, there was a reduction in face-to-face contact with healthcare professionals and third sector organisations. And in the first wave of COVID, testing for HIV and Hep C in drug services and prisons decreased by 94%. And that's a study from Caledonian University. Next slide, please. Drug services reported clients who injected drugs were isolating together to reduce social isolation, and then there's the increased risk of sharing injecting equipment. And when COVID restrictions were relaxed, some people were still quite reluctant to attend face-to-face appointments, and the World Health Organization strongly recommend offering self-testing for hepatitis C. Next slide, please. So in Grampian, we thought, how do we overcome the lack of testing? We did think about oral swab testing, but then you only get an antibody test. If we do dry blood spot, then we can get a PCR test and we can identify those who are viremic and require testing. And it cuts out a step really. So clients were offered a postal bloodborne virus dry blood spot self-testing kit when engaging with services, if not face-to-face. And these were given out from the liver nurses, drug and alcohol services on release from prison or custody suites, and COVID-19 vaccination centres. Next slide, please. So in the pack, it included a testing kit, and we also checked if patients had a sharps container. If they didn't, we would send them out one as well. A prepaid envelope to return the test, and detailed instructions along with diagrams on how to perform the dry blood spot test. And we also produced a web link to a video demonstration. And because of COVID-19, our graphics department weren't able to come and film us face-to-face, so It's quite a kind of basic video that we filmed on an iPhone, but it was enough just to get the instructions out there so people could see how to do it if they'd never done it before. And our goal within NHS Grampian was to make BBV testing convenient and accessible to all who may be at risk in tandem with other methods of testing. So it wasn't the only method of testing. If patients were being seen face-to-face, this was still being offered, but this was an additional method. Next slide, please. So the process really was that the kits were provided by Alcohol and Drugs Action. They were doing doorstep drops for needle exchange, and they would also drop off a dry blood spot testing kit as well, in the hope that they would do it and send it back. We would also send them out from the liver nurses and the third sector organisations, and CPNs would also send them out. If it wasn't the liver nurses who were sending out the kits, then we asked the services to let us know who they'd sent the kits out to so we could watch out for them coming back, and it would give us an idea of how many were unreturned. I'm not sure that always actually happened. And then all tests were returned to the liver nurses to check, and we checked the details on the lab forms and also on the cards, and checked that the sample was adequate to send to the lab, because we didn't want them going to the lab and they've been insufficient. It meant that immediately we could contact the patient and say, look, there's not enough sample here, we'll need another sample, or whatever. We also did a bit of a pilot, and we'd sent out a questionnaire to included in the pack, asking clients for their feedback on what they thought of the testing. Most were very positive, saying that at least they were getting some form of testing during the pandemic. They found the video and the instructions quite easy to use. I would say that sometimes the lab form didn't come back completed, or sometimes it completed and there was blood on the pages. So we changed tack a bit, and we just produced a slip with basic information required to fill out the form. And then when the samples came back, the liver nurses would complete a lab form. And it also meant that we could check the lab system and see exactly what blood tests were required. So if we already knew that someone was Hep C antibody positive, then we would go straight to ask for a Hep C PCR. And it meant that, if there was very limited sample on the card, the right tests were being done. Then we just produced a spreadsheet, and on a weekly basis, we checked for results coming back. And the liver nurses provided results to individuals, and if they were positive, we would arrange treatment. So it kind of cut out the middleman. Next slide, please. So the results, it is still quite small scale, but at least there was some being sent out. So about 249 kits that we have recorded were sent out. And quite surprisingly, 222, about 89% were returned. 27 were not returned. Sufficient tests, and a lot of people thought that people wouldn't be able to do this at home, and 78% of the tests were sufficient to be sent to the lab. Some of them were partially sufficient, which meant maybe they only had 3 full spots and not the 5, and we've still got 4 in progress. Next slide, please. And this is the number of specimens returned per month. You can see it's gradually just increased. There is a spike in May 2022, and I think this was maybe some of the CPNs were pushing for dry blood spot testing. Some of them actually may have been returned and have been performed by the staff helping the client. We're not entirely sure, but we've since asked CPNs if they're doing the tests to send it directly to the labs instead of sending it back to us. So hopefully we'll get more accurate figures. I think that's what the peak is there. Next slide, please. So looking at the different groups, those who returned the test and those who did not return the test. So there's not much difference in the age or gender, but I think what's notable here, the numbers are quite small, is that if they had a previous BBV screen, then they were more likely to return the test. So it might mean that they were more confident at doing the test and knew exactly what to do. Next slide, please. And insufficient samples by test. So we did find that the one reported most to be insufficient was for Hep C PCR, and that was the one that we were most interested in getting. So we had discussions with the lab and asked if they could change the order of testing. So, and with the liver nurses then checking what bloods had been done previously, if they'd recently had an HIV or Hep B test, then that might not be the most important one to get. So we would request for Hep C PCR to be prioritised. And if they were already known to be Hep C antibody positive, we wouldn't ask for that test. Next slide, please. And the services sending out the kits, so substance misuse service, that's mainly CPNs, were the highest people sending out the test, liver nurses, and we also sent out test kits to people post-treatment to get Hep C SVR data. So 3 months post-treatment, we would send out a kit to see if they had cleared Hep C following treatment. Some were unknown, we just got them returned. Third sector, custody suite, we're quite pleased that they were sending them, and the vaccine clinic was quite a low number returned. And we had targeted vaccine immunisation clinics where it was for people who maybe inject drugs, but we were actually finding that they weren't turning up to the clinic, and because the lists were quite low there, other people were coming to the clinic that weren't at risk, so we weren't targeting the right population. Next slide, please. So here's the reason for the test. So some were SVR PCRs, as I've said, Hep C antibody positive but PCR unknown, and some just needing a BBV screen. Next slide, please. So the outcome is that we found Hep C PCR positive in 14 individuals. That was 6% of the total. One patient was Hep B surface antigen positive, but he was already known to the service and he had fallen out of service, but we tried to re-engage him unsuccessfully, and no HIV positive tests. So to date, 8 have already been treated or are currently on treatment. 2 are awaiting review. These are fairly recent positive tests, and we're just trying to get hold of these patients. One's deceased and one's relocated, and 2, despite about 4 or 5 attempts, have DNA'd. So previously known Hep C antibody positive patients in total, of those that sent their results back, were 110 known antibody positive. 61 had previous treatment. Spontaneous clearance probably been at about 19. And we think that 3 were maybe reinfections. Next slide, please. So in summary, we think it was a worthwhile project, and we'll continue doing it alongside other more conventional methods of testing. We're thinking about introducing it into community pharmacies, and maybe some GP practice have asked for it as well. Utilise COVID contact tracing staff to send out packs to monitor numbers requested, and make packs and documentation a bit more professional. It was quite rapidly put together and maybe not as professional as it could have been, but it was the best we could do with what we had at the time. Next slide, please. We also had started requesting 2 cards if possible, ensuring at least one was completely filled, so that the number of insufficient tests were reduced, and I think that has worked. And as I said before, we've changed the order of the tests so that because the most likely one to be positive was the hepatitis C. Some people have asked, well, do we have the capacity to keep getting the test sent back to us? But I think it's really valuable because it ensures that the correct details are on the form, the sample's sufficient, and only request the tests that are necessary. And then we can offer treatment to those that are positive quite rapidly. Thank you.
Thank you for that, Pauline. That was so interesting. Again, it's another alternative way of testing, and I love the fact that you just got in there and you constantly reviewed and constantly changed what you needed to do to get the outcome that you were looking for. So now we've got Professor John Dillon. He's going to present to us developing the foundations for elimination of HCV and evaluation of pathways to reach whole populations. So looking forward to hearing that, John. Thank you.
Hi, Norma. Thanks for the invite to So what I want to talk about is sort of what we've done in Tayside, but using it as an exemplar for what's happening across what other people are doing across Scotland. So it's about developing the foundations for our move towards elimination. The Scottish Government is still committed to that move towards elimination. So it's how we're going to do that across the whole piece. Next slide, please. So I think we should start with the people first, and the people that we're trying to reach. And many of the people that are easy to treat have already been treated, and we need to think about expanding both our testing and our treatment beyond the ordinary. So clearly the one group that we're trying to target are those people who are on opiate substitution therapy. So if you do a discrete choice experiment with them and ask them how long they're prepared to wait for testing, it gives you an idea of where they prefer and where they feel comfortable. So being seen in their own pharmacy rather than some other unfamiliar pharmacy, 4.5 weeks. Own pharmacy rather than GP, 2 weeks. Own pharmacy and key worker, drug worker, they valued equally. And being treated with respect, which is rather damning for the services we did this in Tayside with, 7.5 weeks. So it shows that people want to keep things local and want to keep things within familiar environments. So that's important. Next slide, please. Sharon and Pauline have already talked about dry blood spot testing and the importance of what that does. This is Tayside data when we introduced it in 2009. So you can see the dark blue bars are the positive results that we found in the drug and alcohol services. So before 2009, very little testing going on, very little positivity. And once we introduced that, a big surge in the number of tests being done and a big surge in the number of positives. But also the rest of the testing and the rest of the positives that was being found in other services didn't change. So this test was reaching a new population that hadn't been engaged in testing up to that point. And I think that's a really important take-home message, that we can think that we've tested everyone we can test because we don't find any more in the places that we're testing, but we're not necessarily testing in the right place. And dry blood spot testing is a test that reaches the parts other tests can't reach. Partly because it can be kept local, it doesn't require venipuncture, multiple staff can be trained in it, so it can be very democratic and widely spread, so it's easily available. I think that's really important. And Pauline's stuff about outreach testing using the same technology is very exciting. If we look at where our results come from, okay, across the whole piece, so this is all of Tayside's data ever since 1991, where hepatitis C testing became available in Tayside up till the end of 2018. So in secondary care, we'd done 80,000 tests and about 1% of them were positive. In general practice, they'd done 25,000 tests and about 3% of them positive. Now, that's been going on for the whole time frame from the 1990s through to the end of the 2010s. But if you look at the specialist pathways that we developed with dry blood spot testing, within addiction services, within community pharmacies, within needle and syringe programs, and within prisons, a very low level of testing by comparison. These are much smaller venues, so they don't have large numbers of people to test, but a much higher positivity. And if you were to look at that graph, you might think, oh, we should do all our testing in those special venues. Can we do our next slide, please? But when you actually look where we found our patients, we found a third of our patients within general practice who are positive, a third within secondary care, and a third within the specialist services that we set up through drug treatments, community pharmacies, and needle exchange provision. Now, clearly, general practice and secondary care had years of advantage in terms of timing to find those patients, but they're still finding them, even though we've got the specialist pathways. And the people detected in the specialist pathways weren't found in the other pathways. And so it's a sign that we need both. We need this combination of all of the things together. And that's really key message to take home. So you need both to reach all of your populations. Next slide, please. And so what do our pathways look like in this graphic? We've got the standardized pathway on the left-hand side of the slide, where you've got testing within a healthcare environment, be that primary or secondary care. The test turns up positive, and then you're referred to a secondary care-based hepatitis C treatment, although that may well be delivered in a GP surgery scattered across the whole of Tayside. We've got pathways within pharmacies where DBSs are done by the pharmacist within the community pharmacy itself. And then depending whether it's a high volume or a low volume pharmacy, the pharmacists themselves can initiate treatment under the MDT and prescribe it and dispense it, etc. Or a specialist nurse can come through that pharmacy and clear up all the patients that need treatment. Within the drug treatment centres, our addiction workers are dry blood spot trained and are encouraged to do that and to test all of their clients. And there is an embedded on-site specialist nurse service who can pick up any positives and start them on treatment. The same happens in the prisons, and the same happens in the needle exchanges. Really effectively, the volunteers within the needle exchanges have been a revelation in how much testing they deliver and how many patients they find. And our harm reduction nurses are embedded in those needle exchanges and will pick up anyone that's positive. And that's a very positive, dynamic relationship that keeps reinforcing itself. So that's what the pathways look like in Tayside. That's how we've delivered our diagnostic services and how we've delivered our treatment services. And many other parts of the country have those pathways replicated, but perhaps less so in the pharmacies and less so in the needle exchanges. Next slide, please. So if we want to move towards elimination, we need to up our game. We need to find all of the patients that we need to reach. And so we set ourselves a 3-year target starting in 2017. 2 years of rapid scale up and a 3rd year of mopping people up. And we thought we had about 800 infected drug users, people who inject drugs within Tayside. That was the modeling data from Sharon. And so we wanted to diagnose 85% of those cases, commence over 80% of them on treatment, and achieve SVR in the majority of those patients. So could we do it? If we had that scale up, could we achieve it over a short period of time? Next slide, please. So if you look at our pathways, I think this is animated. So if you could press the animations, the labels will appear. So sort of next slide. There we go. So conventional care delivered about 12% of the treatments, but a high completion rate and high SVRs. If you looked at the drug treatment centres, they supplied 6% of the treatments. The community pharmacies did 20% of the treatments. The needle exchanges did 28% of the treatments. The nurse-led clinics, 17%, and the prisons, 14%. All of them had a high completion rates. All of them had high SVR rates, which was good news. Loss to follow-up thereafter treatment varied between the different sources, where clearly community pharmacies had a very high follow-up rate and a very low loss to follow-up rate because everyone was coming back for their methadone therapy directly afterwards, whereas in the needle exchanges, it was a much high loss to follow-up. But we knew those patients had completed treatment and achieving high SVRs in the patients that turned up for SVR. So we're confident that they're treated. So in terms of that surge, most of the heavy lifting got done within community pharmacies and needle exchanges. So if you want the surge, that's where you need your pathways. Next slide, please. So did we achieve our targets? We passed our targets. So we diagnosed 718 PWIDs of our estimated 800 possible. We grossly exceeded our treatment levels, and this is 2020 data, but with follow-up, we've closed that gap further between the 718 and 662. And our SVR rates were very high, and they'll get higher as we will eventually come into contact with those people who we've treated, but we've lost, and they recycle through our systems. So we'll find them all. So you can step the treatment up rapidly, you can deliver it, it works, so it's possible. So we've demonstrated it in Tayside and it's achievable. Next slide, please. If you stand back and look beyond people who inject drugs across the whole population, so if you take the chronic prevalence of hepatitis C to be about 0.5% within Tayside, now you can vary that number, it's an estimate, but it's the best estimate that we have. That's going to equate in Tayside to 1,975 people, and 90% of that chronic prevalence will be 1,776, and that 90% chronic prevalence is the World Health Organization target. So if we look at Tayside data, on our total ever diagnosed is 4,308 people. This was in June 2020. 980 of those are PCR negative, so they're not a worry to us. 694 have moved away from Tayside, so there's someone else's problem. 664 of those people have died already, and so their clearly they're not people we can reach. And the total alive and living in Tayside with hepatitis C is 1,970 that we've diagnosed. So we've nearly diagnosed all of our chronic prevalence, and it probably means that our chronic prevalence number is a little low and it should be higher. And of that 1,970, as of June 2020, we had treated and cured 1,813 of them. So exceeding the WHO targets and exceeding the 90% treatment of all of those with chronic infection. That gap of 160 odd patients is now down to 32 people. We know where they live. We review them every 3 months and try and encourage them into treatment. I leave you to imagine the rude words that we get in response to our recurrent approaches to people. And some people have made it very clear that they never, ever want their hepatitis C treatment or in the future. We still leave the door open to them if they wish to make contact. So we have a hard core, but it's very small, of people who don't want to be treated. Clearly, there are still a few people to find within Tayside, whatever the chronic prevalence looks like, but that's how we feel we have achieved the elimination targets. The key thing going forward now is to keep our diagnostic efforts going so that we keep finding the few remaining primary infections and we check regularly for reinfection, and our reinfection rates appear to be falling. The amount of data we want around that has been limited because of a reduction in testing around COVID, but we're picking that up now and we're moving towards it. Can I have the next slide, please? Thanks very much for listening. I'm taking the credit for this, but it's the people who are named on this acknowledgement slide who did all of the hard work, and it's their achievement along with all of the other clinical staff in Tayside and the patients and people of Tayside. Thank you very much for listening.
Thank you so much for that, John. Again, it's amazing to see what's going on in Tayside and how far you've come and what's possible. Our next speaker, as I said, it's going to be a video presentation, and it's Billy Hamilton, who's my colleague here at Hepatitis Scotland, interviewing Scott. And I think it's great to actually hear from somebody who's been through both treatments and can compare, because I know that some people are put off treatment because of their previous experiences.
Hi there, my name's Billy Hamilton. I work for Hepatitis Scotland, and I'm here with Scott. Hi, Scott.
Hi.
And Scott's kindly agreed to this discussion because he's got experience of both the old treatment and the new treatment in regards to hepatitis C. So thanks, Scott. Can you just give us a brief background on how you believe you might have got hepatitis C, or do you know?
So to be honest with you, I don't actually know the exact time that I caught hepatitis C. But what I do know is I started using heroin very early age, uneducated on it. That then turned to progressed into injecting intravenously. A lot of people done it again, had no knowledge of anything to do with bloodborne viruses or anything like that. Do you know what I mean? And then it was just years later. When we were in prison, this thing came out about, I think it was back in Clonoko, they were talking about HIV, the spread in the jails and stuff. And then that's when they were testing hundreds of people for stuff like that. And then they roll out, it was all about the hepatitis. We were in the jails at the time, and they says about us, and we just done that, you know what, and got tested. And that was the really first time that we actually knew anything of it, to be fair. So
that was the first time you really knew anything about it, when you got tested and it came up positive, is that right?
Well, there's quite a lot of us get tested in the jails for it, and it all came up positive, and a lot of people actually went out with positives, right? Probably went to then go and then give me a paper, do you know what I mean? Because at this point they were just talking about these treatments and stuff like that. And then it's when I came back in jail the next time, they were saying about interferon, this thing that was going to take this away and stuff like that. And that's what they gave a few of us done in the jails and maintain it.
So did you know much about treatment, or was it just that's what was there and you just...
I didn't even know much about hepatitis, far less about treatment. So people would then start saying stuff and giving information about treatment to things that we didn't even know what it was. Do you know what I mean? It was like right, so if you're saying we've got this and whatever it is, then get rid of it, that's fine. Do you know what I mean? So aye, that's what we've done. A lot of us just took this treatment.
So the first course of treatment, the old treatment you had, how did that come about? As you say, was it just that they said to you in prison, this is what we've got for this thing that you didn't really know much about, and you went, aye, okay. Was that about right?
Aye, and then next thing we know, we're taking hundreds of these tablets on a daily basis, big horse tranquilizer things, and then we're getting an injection on a daily basis and that as well. And I just, out of everybody that taken it, I don't even know anybody that I actually worked on. Do you know what I mean? It made a lot of people ill. Do you know what I mean? And my recollection here is, I felt as if I had a hole in my head. It was like an aneurysm hanging in my head. It was horrible. It was a horrible, horrible feeling. Just felt dead ill. Do you know what I mean? I couldn't get out of my bed or nothing. Do you know what I mean? Oh, it was horrible, horrible stuff.
Aye. So it didn't work for you, the old treatment? No.
No, I didn't do nothing. Never done nothing apart from making me no well. And then after that, it was just any talk, anything to do with anything like that. It was just.
Aye.
You know what I mean?
I was going to say, so how did you think going forward? Now I've got this hepatitis that you didn't really know much about. I've had this treatment that's not done anything for me. What was your kind of thought process going forward?
That point again, it was about the time and ignorance, man. Ignorance and uneducated people. Do you know what I mean? So we didn't know nothing about it for the people that actually had it. So people then, it's to deal with people that's got that. It's do you know what I mean? It's not a good thing. So for instance, even I don't like my family. So it's the only thing to hang me that with is HIV, right? So people then put that in the same bracket as that, and then the stigma arises as a result of that. Do you know what I mean? So then people have got that, and I was one of these people. It's like, how do you extend your to your family, right? So my mom and all that was like we Chinese of blood and razors and all that. Do you know what I mean? Tools and things, and so I don't know if you can catch it through saliva, forks and things like that. Do you know what I mean? So all that thing came in, and then you're getting into things like relationships and stuff like that as well. Do you know what I mean? And so it was a horrible time.
So how did the new treatment come about for you? And did you still have barriers about that? Did you still think?
Yeah, again, that was all done through prison and all. And the jail found out that this new treatment had been about. It was just starting. There was a few people who'd already started it. No side effects. It was one tablet that were taking. Do you know what I mean? It was like 12 weeks, and that was it. They were ready. Do you know what I mean? So it actually seemed too good to be true, to be honest. You know, I just like all this other stuff, but I seen folk that was doing it, and I've done that. Do you know what? Why no? Do you know what I mean? Because it's a big thing hanging on your shoulders, and when obviously everybody, 9 times out of 10 people have got this. They've got drug addictions. Do you know what I mean? And this is a big thing. Do you know what I mean? Once you've got this lifted for you, do you know what I mean? It's a big weight. So a lot of people take drugs just to get away from things like this as well. Do you know what I mean? Yeah.
So would it be right in saying that you were, when the nurse told you, did you believe her right away that this treatment was completely different to the old treatment, or did you be a bit?
Yeah, the same. Do you know what? I didn't believe it. I was very apprehensive about it, and it was only through seeing other people that had been there. Do you know what I mean? Like it's been through treatment, and there was nobody that had actually been through the old treatment to marry up against. But it was just folks saying I have no side effects. Didn't know if it was working. Just knew that there was no side effects for it. Do you know what I mean? So that was enough for me to actually go forward with it.
So people were like, nurses were telling you, but you only really believing it. Is that right? Aye. So it was other people, so that kind of power example, and other people run about you, that's convinced you, right, okay, I believe them, you've done it. So can you describe how the new treatment was, then the effects, any effects on it?
I actually had no effects whatsoever. As I say, I was just taking one tablet a day, do you know what I mean, for 12 weeks, and I think it was after the second week, it was in the blood test, it was gone. Do you know what I mean? And so I was like that, well, you know, because again, there was no side effects whatsoever. So it was just without your mind. Do you know what I mean? You're just taking it and that's it. Do you know what I mean? So it just without your mind. But then obviously, when you're getting told it's gone, do you know what I mean? And then you're a wee bit hangmaze, like, is it going to really be gone and stuff like that? And then you're like, well, is there, because I always thought, well, do you know what, it's not affecting me like physically and stuff like that.
Yeah.
But it definitely did. It definitely was affecting me physically, do you know what I mean? Because I became a lot more active, do you know what I mean, as a result of that. But I think even more so mentally, do you know what I mean? Mentally, it was a big weight lifted, do you know what I mean?
Yeah, definitely. I mean, that's what I hear with a lot of people do. More energy, but more kind of focused in their mind. Would that be right enough?
No, 100%. And I think the focus just comes from the simple fact, do you know what I mean? You've got that, right? That's not just a thing that maybe you don't even understand. It's also the stigma and everything that's attached to it. Do you know what I mean? The shame and all that. Do you know what I mean? It's a horrible, horrible thing. So just getting away from all that alone, do you know what I mean? Is a big thing, do you know what I mean? And there's hundreds of questions that you don't need to then explain. Do you know what I mean? If you know what I mean?
So was you a lot more confident, you think, as a person after that when it's gone?
No, 100%. As I say, for instance, if for instance, you can't think you can move forward with your life as well, because for instance, new relationships with anything that's worth being in a relationship, do you know what I mean? So that's a big barrier to overcome, things like that. Do you know what I mean? If that's something that you've got, do you know what I mean? How do you explain that? And then you've got to take into consideration, you don't know how the person reacts to that with regards how shut off they're in their mind, do you know what I mean? So it's a very difficult thing, and questions you'd just rather not have.
Aye. So obviously it'd be right in saying that you were apprehensive about the new treatments because of your experience of the old treatment, which, well, it didn't work for you, but also the negative effects of it. So for anybody sitting out there who's maybe heard stories about the old treatment or maybe experienced it, what would you say to them about going through the new treatment?
With regards to the old treatment, if somebody's went through the old treatment, then it's like night and day, totally night and day. There's nothing, do you know what I mean, compared to this. And for anybody that's no, and they're just sitting with that, do you know what I mean, then 1 tablet a day for 12 weeks, do you know what I mean, no side effects whatsoever, and then you've got the rest of your life to go on as a result of that, do you know what I mean? And that's what it is. And for anybody who's even dealing with anybody who has got hepatitis, do you know what I mean? The stigma attached to that alone, the way we need to look at that now is there's a tablet there, they can get rid of that in 12 weeks. There's some sexually transmitted diseases you can't even get rid of in that short of time. Do you know what I mean? Yeah, but look at it differently. Definitely.
Brilliant. So what's your plans for the future, Scott?
As I say, I'm doing all right with my life, know that now, away to college, away from that life of crime, all that, away to college, became a recovery support worker, and do you know what I mean? And now I'm actually looking at other where I'm going to go future, do you know what I mean, in my life, do you know what I mean? There's a few things opened up for us, and I'm just actually seeing where to go with it next.
Good. And do you think clearing your hepatitis has helped you in that journey?
I wouldn't say, it's helped me, as I say, with the confidence part of things, do you know what I mean? Right. Everything else, because obviously with that, do you know what I mean? That was ready. That was one of the other things that was holding me back with the drugs, do you know what I mean? I kept taking because of this. So that was just like one thing less, do you know what I mean? For me to use as an excuse.
Definitely. Well, thanks very much, Scott. I really appreciate it. Thanks for doing this, and hopefully if you can help one person out there make the same decision, it'll be really worthwhile. Really appreciate it. Thanks very much.
Thank you so much to Scott there. It's so good to hear it from that side, from somebody who's experienced both, and he's such a big advocate for treatment. As usual, we're running a bit over time, so I'm going to jump into the Q&A. I would like to welcome Alastair Hudson from HIV Scotland, and Billy's going to join us. Unfortunately, Professor Dillon's had to leave, but we will crack on. So I think a couple of the questions that we've had are talking about bloodborne virus testing in the third sector, and looking at what kind of resources would be required to support the third sector to do testing. Pauline, are you working with third sector? Do you have much to kind of do?
Yeah, we work quite closely with third sector, and to be honest, they're really keen to do the testing. And I think since we started the self-testing, they've realised that if clients can do it, there's no reason for them not to be able to do it. So it's a simple enough method to do. I think there was a lot of kind of concerns about if the test was positive, how would they, give the result over and things. But I think with regular training, and they can contact us at any time. I mean, they've got a direct line to us that they can phone if there's any concerns at all. If the client is concerned at that time, we can speak to them over the phone or whatever. So I think, clinicians supporting the staff to do it really helps.
I think certainly what I'm getting is that I think it's about joined up working. I think that it's about nobody kind of working in silos. I think that pathways need to be in place so that you can ensure kind of results are getting to the right people in the right way. And so I think, it's about kind of joining up and talking it through and developing pathways. And then I've got, so for sending out dry blood spot HCV self-test kits in the community, was there a way to capture those who didn't have a heightened level of oversight from a nurse? And if so, what was the return rate? So I'm guessing, again, Pauline, sorry, it's coming back to you, but I'm guessing that they're talking about, maybe you were speaking about some of the CPNs were doing it. And I think the question's around, if you didn't have somebody there, was there a lower return rate if you weren't supported in some way?
It's kind of difficult to tell because of the model that we used, but I had spoke to someone at Change Grow Live before, and I think that they had done some testing and the return rate wasn't anywhere near that. I can't remember what it was. I'm going to say about 40 to 50%. It might even have been less than that. But I think for us to get a real idea of return rate, we'd need to have a kind of tighter method of seeing how many cards are going out, etc. And I think that's why it would be good if someone from public health or whatever could do all the sending out of the cards, and then they come to us and they could record who it's been sent out to. So if there was like one distributor to send it out, that might help. But then again, there's opportunistic testing as well. So if someone turns up to a needle exchange and wants to do their own test, it would be great to have some there as well. So if there's some method of recording that, it would be good, but it's difficult to tell.
Yeah, I think going back to again what John was saying, it's it's about getting as many people involved, and a lot of people are going to pharmacies and like the pharmacy approach, but I think it is just again being creative and casting the net as wide as possible. But I'm getting lots of questions in now suddenly. Who do you contact to receive training for dry blood spot testing? Anybody want to answer that?
I know previously you would get, Sharon's going to do
it. I guess I wasn't going to answer that specific question, but I mean, we've got World Hepatitis Day today, and which is about awareness raising, and I think there was a theme of awareness that came through in that great video that we saw with Scott about awareness of the new therapies, and I think it is about I didn't know whether Pauline had a sense of what was the awareness amongst people that we need to reach in terms of Hep C testing, in terms of, say, this new postal dry blood spot testing service. And I see a kind of third sector colleagues playing a really key role here in raising awareness, because I know early on in the kind of following the introduction of the new therapies, awareness was still very low. I'm hoping that has really increased since then, but we've always had a pandemic, and there's been other things that have been on a daily radar. So I think this is an opportunity to get us back to raising awareness, promoting the new therapies, and promoting these different new ways of reaching people through new testing and treatment initiatives. But I just wanted to raise that point: is the more we can do then in terms of raising awareness.
Interesting you should say that, Sharon, and I need to do a bit of shameless plugging for Hepatitis Scotland here. Myself, Billy and Kate Lindsay are very focused on awareness raising. We're targeting 3 groups. It's a 1 hour awareness raising session and it covers all of those things. We're targeting specifically community groups that are not necessarily working directly with people that use drugs or bloodborne viruses, but like house and council staff. We're targeting people that are at college, so future caregivers, people doing HNCs and kind of health and social care. And finally, we're doing some awareness raising around peer groups. So yeah, shameless plug for Hep Scotland. If anybody wants to know anything more about the training, contact myself or Billy and we'll hook you up. Alastair, how are you doing with sound yet?
I don't know. Can you hear me? Is that working?
Yes.
Glory be.
I'm going to have to wind it up, but is there anything that you want to kind of add? I'm so sorry we've not.
It's fine. Just quickly, I think it's really encouraging that there's options. I mean, I worked at FPA for years, and you know, I'm much as I'm a CEO of HIV Scotland, I'm a community member. I was diagnosed with hepatitis and HIV, and I went through the early treatment, so I kind of speak with a wee bit of authority, though it's historical now. I think the thing about testing that we learned from family planning is it's about choices. I mean, dry blood spot testing in place-based environments, and a postal offer. I mean, I'm really wary of the word elimination because we're not going to eliminate things. We're going to basically reduce them significantly so they can become manageable. But I think the options and the choices are the key to the change piece here. And I think, you know, the partnership working, joined up thinking, lack of duplication, and common sense. You know, there's going to be less money. Everybody's going to want cheaper, better, faster. And it's a feeling. My mother used to have an expression: "Kick one of us, we all limp." He says with his inimitable Glasgow patois. I think it's really, you know, we need more joined up thinking. Organisations like HIV Scotland, Hepatitis C, and SDF working together. We're on the same boat. Let's just start rowing. Seems simple.
Yeah, let's go on with it. No, thank you for that, Alastair. I really appreciate it. Lastly, it just falls on me to thank the speakers so much. Sharon, Pauline, Alastair, thanks for coming along. John and Billy and Scott. Massive kind of appreciation to Lisa and Sophie from our comms team. And any questions that we've not managed to answer, we'll try and answer them and send you the post the results somewhere. But thank you so much for joining us. And if there's anything at all, just give us a shout at Scotland. Thank you, everybody. Enjoy the rest of your afternoon.